We have people out today because they got vaccinated and they're feeling the side effects. I will say my arm is pretty sore. And make sure it's in a non-throwing arm. So when I send emails out via Blackboard, do you get them?
I just didn't get the handout one.
Because I sent it via Blackboard. Because when you email me and I answer it, you seem to get it. But when I send one out via Blackboard, do you not get those?
Not via email. So maybe I just need to be checking my Blackboard.
It could be that the system doesn't have the email you normally use. Do you use your school email or do you use something else? Use your school email. Let me check that and see if there's a different email. If there is, I'll need to change it to the one you normally use. 2, sometimes if your mailbox either gets full or, okay, or sometimes, oh, what did IT tell me once? If your email during the day it will go down, it doesn't necessarily archive emails. You just don't get them sometimes.
Is that a question?
Yeah.
My mail goes to archive. So I check my archive and my inbox. Because emails just go to archive and I don't know how to change it.
That's not it then.
I don't know.
Yeah, I don't know why you didn't get that handout. When you said I haven't seen that before, my heart sunk. Because I made reference to it in class. You needed that, so. Okay, well, next time I send something via Blackboard, I have to make sure that you received it so that you actually get it. Yeah.
Oh, no. Come on. No, you're not. I know.
All right. Let's go ahead and get started. So we have some people out because of side effects from the COVID-19 vaccine. That's good news. That means it's working. So I'm glad you guys were able to get your first jab, but we still have to soldier on. So we have some folks on Zoom. That's okay. That's why we continue to Zoom and why we continue to put these lectures on YouTube for your viewing pleasure. Well, pleasure, I'm not sure pleasure comes into it, but. Okay, so we're going to continue our discussion of coagulation and anticoagulants. We'll look at specific drugs today and side effects and what have you, and so on and so forth. Let's have a word of prayer, then let's begin. Our Lord, thank you for a little warmer day today. Thank you that students and staff are getting their first shots. Now, please watch over us. Help us to live smartly. Thank you for all you do for us. Continue to lead us, Lord, into the home stretch of this semester. In Jesus' name, amen. Hard to believe we're getting close, isn't it? Okay, so we talked last time about the CHAD-VASC scoring system. And we saw that these various factors can increase your risk for a clot. Now, there is also a little spreadsheet on page 79 of your notes. So if you could please get that out. So if we take a look at this little spreadsheet here, so notice at the top it says balance of coagulation. Balance of coagulation. That typically means you have factors that will favor and disfavor coagulation. Now, things that greatly increase coagulation can be summarized using the so-called Virchow triad. Come on, Pam. Virchow's triad. And Virchow's triad, as you might think, triad is three things. So we're going to use the mnemonic she to remember Virchow's triad, she. So S refers to stasis. Stasis of venous circulation. So a clot is going to form in the vein. You will remember, maybe, that the vein has these little valves, these one-way valves. You don't see these in arteries, do you? Yeah, that was a question you're supposed to answer. No, you don't. That's a unique feature of veins. When the vein experiences stasis, you get blood and corpuscles and stuff essentially accumulating behind the cusp of this vein. So the blood is flowing in this direction, and the more stasis you have in the vein, the more you get an accumulation of material behind the cusp of these valves. Now, typically, in your veins, your skeletal muscles are contracting. So when you walk, or when you run, or when you climb stairs, or when you go to the gym and do squats, or when you play hockey, or when you run the bases, or when you're in the batter's box, or when you're pitching, or when you're on the tee, Katie, and walking to the next hole. How'd it go yesterday, Katie? How'd you guys play? Good, good. So you played well, good, excellent. So Katie yesterday was essentially working out her little skeletal muscle pumps, essentially. When you're not moving, your skeletal muscles are not pumping the veins. So when are you going to have periods of inactivity? Let's brainstorm periods of inactivity. Sarah, give me a period of inactivity. Sitting and studying. That's why you should get up and walk around every 40 minutes to an hour. What else? Hope, give me another incident when you might be inactive. When you're sleeping. When you're sleeping. So don't sleep all day. That'd be a good motto there. What else? Sarah? Well, what about if somebody spikes you at third base and you get a fractured fibula? Okay, first of all, that'd probably empty the dugout. Secondly, what's going to happen to you then? You'll be laid up, you'll be inactive. What happens to people in the hospital after surgery? I see Elena sitting there going, yep, 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 yep. Elena, what happens when you're in the hospital after surgery? Inactive, inactive. That's why after surgery, they get you up, they get you moving. You're like, ow, 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 uncle, can I please go back to bed? No, they keep you moving. They keep you moving to prevent the stasis. So stasis of venous circulation, that's the first one. Traveling can do this too. That's why physical therapists now have these exercises. If you're on the plane, you're supposed to do 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3. You ever seen these exercises, Mitch? As you've seen them, and then you're supposed to do this and then do this and what have you. And you're supposed to do that every half hour or 35 minutes or whatever like that. And that's supposed to help with the constriction of the skeletal muscles in your legs. People don't do these. So physical therapists can make YouTube videos and get rich. They do this because stasis is a major factor for risk of DVTs. Okay, so stasis of venous circulation. H is hypercoagulability. Oh my goodness, that's a lot of syllables. Hypercoagulability. Let's think of situations that increase your coagulation. Things like cancer, things like severe illness, sepsis, dehydration, birth control. Something we're going to see called heparin-induced thrombocytopenia, or HIT. Also, pregnancy, particularly after the postpartum period too. Those are when you have hypercoagulable states, those increase your risk for a venous thromboembolism. And then E would be endothelial damage. Endothelial damage. So indwelling devices like IVs, catheters, central lines, artificial heart valves, diabetes mellitus, trauma, injury to vessels, medications that are hard on the endothelium. All of these can damage the endothelium. That raises your risk of a venous thromboembolism. So Virchow's Triad, your mnemonic is she. S stands for Katya. Okay, Corinne, H is for, very good, Rem, AE stands for endothelial damage. Endothelial damage. If you study with a group with each other on the states that might cause stasis of venous circulation, hypercoagulability, or damage to endothelia, that will give you a leg up essentially on all this. All right. Let's go back to our slides. Okay, and Josh, I inquired about the 6.7. That's not a mistake. That's what they published in the paper. I actually typed it correctly. That's just the way the data fell out. But you can still see there's an increase. That's the trend. As the CHAD-VASc score goes up, you have an increased risk of a thromboembolism. venous thromboembolism. Okay, so clots. There's two ways to address clots. One, you prevent them. You prevent them with various types of medications and various other strategies that we talked about, getting the patient up, walking after surgery. That's also when you have a C-section, the nurses will usually get you up and make you walk, which is awful because you're in a heap of pain, but they'll force you to get up and walk. You can then use a group of drugs to dissolve the clot called thrombolytics. Thrombolytics. Thrombolytics trade on a very powerful protease in the body called plasmin. Plasmin. So as you can see here, plasmin. Plasmin is made as a zymogen. Here's the zymogen, plasminogen. So that's made by the liver. Oh, that's not too shabby. Made by the liver. And it gets clipped by several different things into plasmin. Now, the one I want to highlight is this one here, plasmin activator. Oops, right here, sorry. Plasmin, tissue plasmin activator. Now, tissue plasmin activator clips plasminogen into plasmin. Plasmin then dissolves the fibrin. It breaks it up into fibrin degradation products. So it dissolves the clot. Dissolves the clot. And if you have a stroke or a heart attack, you can use these drugs to dissolve the clot. These are very powerful medicines. They carry very definite risks of bleeding. So you have to use them very carefully. And when you use them, you have to monitor the patient like a hawk for bleeding. Now, a word about plasminogen. Plasminogen circulates in the blood, but it has an affinity for clots. So TPA tends to activate plasmin when the plasminogen is bound to the clot. Doesn't activate it in the blood. That decreases your risk of bleeding. That's going to be important when we talk about our thrombolytics. Okay, so the thrombolytics are recombinant DNA versions of tissue plasminogen activators. They're recombinant DNA versions of tissue plasminogen activators. So the TPA gene was cloned, protein is overproduced, and then that protein is made commercially available. So the first of these is called alteplase. Alteplase. That's a recombinant TPA. That's essentially TPA pretty much just like it is in your body, except you're giving a lot of it. That goes by the trade name of Activase. Activase. This has a short half-life, about 5 minutes. It tends to activate plasminogen bound to a clot, but it will also activate plasminogen that's circulating throughout the bloodstream. Having said that, it's fairly selective for the clot-bound plasminogen. Now, a word about these drugs. Remember, we said that the clot, after it forms, gets cross-linked by factor 13. That takes time. Because it takes time, it means that these work on young clots much better than they work on older clots. Therefore, after a period of time, these thrombolytics really won't work very well on the clot because the clot is cross-linked. So the other rule about thrombolytics is that the sooner you use them, the better. The sooner you use them, the better. So alteplase is the only FDA-approved treatment for strokes. Sorry? Because the protocols haven't been worked out with the other ones. Now, there's two kinds of strokes: obstructive stroke and hemorrhagic stroke. Which one do you think this works for? Obstructive. You do not give this with a hemorrhagic stroke. Your patient will bleed to death. Yep. And now your body's trying to plug the hole in that blood vessel, and now you've just given them something that'll prevent that from happening. Your patient will bleed out right into their brain. Congratulations, you just killed them. How do you confirm it's one or the other? You do a head CT. So if someone has a stroke, they get to the hospital, imaging. That's the first place they go, imaging. You must use alteplase within 3 hours. There are some protocols where you can use it within 4.5 hours, but that decreases your candidates then who are eligible for it. Now, when you give it, you give usually a bolus and then you give a constant drip. You watch your patient for neurological deterioration. If you see neurological deterioration, you pull the drug immediately and call the doctor. And then you must exquisitely control the blood pressure. Exquisitely control the blood pressure. You have to keep the systolic blood pressure between 140 and 150. And you must keep it below 180. Usually with a stroke, the blood pressure is up, but you really need to try and keep that blood pressure down. For a heart attack, the cutoff time is 12 hours. And there's two protocols. There is a 3-hour protocol, you give it over 3 hours, or there's an accelerated protocol where you give it much quickly. Different hospitals will have different protocols. Some hospitals use both. And the other thing you use it for is a pulmonary embolism. A pulmonary embolism. For stroke, for hemorrhagic stroke, very often you need to relieve the pressure. So usually you'll drill a hole in their head and relieve the pressure. And then when you drill a hole in their head, you can usually use that opening to repair the damage. That type of surgery is some of the most fiddly surgery, neurovascular surgery. That's very fiddly. You're working under a microscope with little micro tools. That's very highly skilled surgery, but there are people who are very good at it. And they do that type of work, and they're quite good at it. Now, PE does not mean physical education. Pulmonary embolism. Let's think about the signs of a pulmonary embolism. First thing you're going to get is, of course, shortness of breath, but it's going to occur suddenly. So sudden shortness of breath. You can't see what I'm writing. Okay, sudden shortness of breath. Next thing you're going to see on their pulse ox electrode, a pulse ox monitor, their oxygen saturation is going to tank. And it's going to tank quickly. So oxygen saturation goes down. Next thing, the heart rate will tend to become very accelerated. They usually become tachycardic. That's pretty common. But the degree to which they become tachycardic will vary from patient to patient. Thing is, if you've got, say, someone who's under anesthesia, and all of a sudden their heart rate spikes and the pulse ox goes down, it's a PE. That's pretty set. Next thing they'll get is chest pain. The intensity will vary from person to person. And then usually with all this, you'll have anxiety. Those 5 things, if I had a nice mnemonic to put that into, I'd use it, but I don't, sorry. But those are the signs of a pulmonary embolism. And you can use Activase for pulmonary embolism, although I have to say that the protocols are not as well worked out, but it is used. It is used. Now, the other thing you can use it for is to clear a central line, because central lines get plugged by clots sometimes. So there's actually a product, it's called cath flow Activase, C-A-T-H, capital F-L-O, Activase. That's used to clear central line. You just basically put it in the central line, let it sit 30 minutes or so. Then see if it works. If it doesn't work, you just repeat, except you let it sit a bit longer, and that clears the central line. So the other products that are available are products that are TPA that have some mutations in it. Those mutations make the protein have a longer half-life. So there's Retaplase that goes by the trade name of Retavase. This is a longer half-life product. It's used mainly for heart attacks. This one is a more active degrader of clots. but it tends to wander around and activate plasminogen that's not bound to clots. So that's a downside of it. Allison? No. 12 hours is a cutoff for when you can use it for myocardial infarction. No. This one, no. The cutoff has to do with when the clot gets cured or when opening the vessel isn't going to do you any good because the tissue's all died. Yeah. No. When someone comes in and they've had an MI, it's clear they've had an MI. When do they start getting symptoms? If it's been 12 hours, then giving them something like this is not going to help. But if it's before 12 hours, then it's going to help. So retaplase is not approved for anything other than myocardial infarctions. It is used for clots under other conditions. So it gets used sometimes for clots, say, in renal arteries, or it gets used in clots, say, for mesenteric arteries. It'll be used for stuff like that. And then tenecteplase, or TNCase, has a very long half-life, as you can see. This is used for hemodialysis because in hemodialysis, the tubing can get plugged. You throw this in there, it keeps it clear. That's when you tend to use it. Also, you can use it if it's clear that by clearing a clot, another clot's just going to form. Then you'll usually use this drug here. So if someone has had severe trauma to a vessel because of a procedure or something like that, you might want to use this essentially to keep that clot from forming and then reforming under these circumstances. Again, you have to watch patients really carefully for bleeding when you're using something like this. Allergies to these drugs have been described. So when you administer the drug, make sure you watch for an allergy. Some patients, when they get this drug, will experience nausea, vomiting, or dizziness. Some will even get a mild fever. Blood pressure may drop. Not always, but it can happen. The real big side effects, of course, have to do with bleeding. So if you're giving it for a stroke, cerebral hemorrhage would be a potentially severe side effect. In the case of a MI, you can see arrhythmias. Systemic bleeds, of course, are always a worry. And then one of the issues with these drugs, if you have a clot in a coronary artery and that plaque underneath is unstable and you dissolve the clot, you can get removal of the cholesterol from that plaque. That can be very dangerous because that cholesterol will tend to stick together and that can get stuck in vessels. That's called cholesterol embolization. Cholesterol embolization. So that can cause a new infarction, and that won't be dissolved by these drugs. Now, when you're working with drugs like this or with other anticoagulants, always know the antidote and always have the antidote close in hand. The antidote for thrombolytics is amino caproic acid. aminocaproic acid. There's a newer antidote. It's called tranexamic acid. Or alternatively, you could give frozen fresh plasma, because those frozen fresh plasma is filled with clotting factors, and that will essentially abrogate the effects of the thrombolytics. So these are your antidotes. Make sure you know the antidotes for all of these treatments. It's very important. Are there any questions about these thrombolytics? All right, this slide is simply to show you that thrombin, after it's activated, actually has multiple factors that will activate the entire coagulation system. So it activates platelets, it activates other components of the coagulation pathway. Thrombin is really at the center of the positive feedback that activates coagulation. So if you inhibit thrombin, you've gone very far towards inhibiting coagulation in general. And in fact, many of your natural anticoagulants that are available in your body target thrombin. And we talked about these already. We talked about these. We talked about these. And in fact, the first anticoagulant we're going to talk about targets thrombin, and that's heparin. So if you work in healthcare anywhere, you will hear about heparin. Heparin is extremely commonly used. So heparin has to be given parenterally. Can't be given orally. It's given intravenously or it's injected subcutaneously. Heparin is a polysaccharide, very complex polysaccharide. So it comes in chains, and there's two main types of heparin: unfractionated heparin and low molecular weight heparin. Unfractionated heparin and low molecular weight heparin. Those are two types of heparin. So heparin is a bunch of sugars, very highly charged sugars that you link together. Now, some heparin chains are very, very long. Others are just long. Or excuse me, just very long. Others are just long. Others are kind of long. Others are sort of long, and then others are kind of short. So heparin is a heterogeneous product. It's a heterogeneous product. That means that its pharmacokinetics is not all that predictable. So heparin needs to be monitored when you give it because of that. So how does heparin work? Heparin binds to this protein called antithrombin 3. Antithrombin 3. Heparin, very negatively charged. Antithrombin 3 has a site, very positively charged. These two meet, they make antithrombin 3 very, very active. It inhibits thrombin. By inhibiting thrombin directly, you wipe out clotting. That's how heparin works. So in order to form the complex that inhibits that activates antithrombin 3 and inhibits heparin, you have to have a sugar complex that's at least 18 sugars long. And if it's only a few sugars long, then it won't inhibit heparin, but instead it'll it'll inhibit factor 10. It'll inhibit factor 10. So heparin can actually do two things to inhibit clotting. And antithrombin 3, you can see here, actually inhibits several different proteins in the clotting pathway. The biggie, of course, is thrombin, but it'll inhibit these other factors too. So heparin is going to shut down clotting very, very effectively. So it inhibits thrombin-mediated conversion of fibrinogen to fibrin. It inhibits thrombin-induced aggregation of platelets. It inhibits activation of the fibrin stabilizing enzyme, that's factor 13. And it inhibits factors 2, 9, 10, 11, and 12. Thrombin, clotting, shut down by heparin, shut down very effectively. That's why it's used so much. A word about unfractionated heparin. Reason it's still used. Number one, it's cheap. Never underestimate the power of economics. Two, because it's not renally excreted, you don't have to adjust for people's kidney function. Three, third reason, the antidote for heparin is protamine sulfate. Protamine sulfate. They took the markers, those cannibals. Chalk, I can understand, but markers, goodness, why are you taking markers? So the antidote for heparin is protamine sulfate. Protamine sulfate. Protamine sulfate inactivates heparin beautifully. Unfractionated heparin beautifully. And it's essentially a one-to-one sort of deal with protamine sulfate. So calculating protamine sulfate inactivation for unfractionated heparin is dead easy. Those are the three main reasons it's used. So now low molecular weight heparin is a very popular product. And if you have a knee replacement, hip replacement, shoulder reconstruction, something like that, you'll usually be sent home with a box full of vials of low molecular weight heparin. And the nurse will usually train you how to inject the low molecular weight heparin subcutaneously. Because after such surgeries, you're at very high risk for clot. Have any of you had surgeries like that where you've had big knee things and you got to do heparin afterwards? Anybody? No? No one's had the pleasure? Okay. So when you inject low molecular weight heparin, you inject 1 inch away from scars. You don't inject into scars. You inject 1 inch away from scars, 2 inches away from the belly button. And you inject into the sub-Q, you inject into that fatty layer underneath the skin. You don't inject into the muscle, you inject into the fatty layer under the skin. So the main product used today in US hospitals at least is fonduparin that goes by the trade name of Lovenox. These are just some of the dosages that you use for, say, after hip and knee surgery, or for if you have a DVT that prevent, remember, these don't dissolve DVTs, these prevent them from getting bigger. Thrombolytics dissolve them, anticoagulants do not. They prevent them. But if you already have them, you can give these to prevent them from getting bigger. The other product is Fragmin, goes by the, that's the trade name, the generic name is deltaparin. And this product, deltaparin, has been discontinued in the US. The company stopped making it because they couldn't make any money off it. So they stopped making it because they couldn't afford to make it anymore. Allison? If you talk to a ICU nurse, she will almost certainly say Lovenox, because when he or she takes the product, the big label that's staring him or her in the face says Lovenox. So they will usually call it Lovenox. Remember, I want you to use generic names because let's say you marry the love of your life and he turns out to be Australian and you work in Australia. They may not call it Lovenox in Australia. They may call it by the, because maybe made by an Australian maker, or maybe made by somebody in Belgium and it gets shipped to Australia and it's a different product because that had to be marketed under the European Medicines Agency, not the FDA. Or maybe it's made in India and has a different name. So just an example. You're already married, I know, I'm just saying we're married. Anyway. Yeah, because that's what it is across the world. Whether you're in Russia or China or Mongolia or Siberia or Patagonia or whatever, the bloody thing is enoxaparin. How it's packaged, how it's marketed, the form in which it's marketed, that's the trade name. But the product, the active ingredient, is wherever you are, enoxaparin. So how do you say enoxaparin in Spain? Spain, enoxaparin, same thing. So although their trade name will be something by a Spanish company, be a Spanish name, but it's still enoxaparin. That's why I want you to know the generic name. Okay, low molecular weight heparin can elicit allergies in some people. So if the patient gets fevers or chills, or if they get urticaria, that is a rash, then the patient might be allergic to it. So what you usually do is you mix up a small batch and you give the patient a test batch. If they handle that fine, then you can give them the low molecular weight heparin. Low molecular weight heparin has very predictable pharmacokinetics because it's a homogeneous product. This product is excreted renally, and you do have to adjust it for renal function. And this is just a structure to show you what low molecular weight heparin looks like. It's these 5 sugars, highly charged, all bound together. And this will predominantly inhibit factor 10. Won't inhibit thrombin quite as much. It tends to inhibit factor 10 more. All right, so if you compare the two, you can see the bioavailability of low molecular weight heparin is quite good as opposed to standard heparin. Low molecular weight heparin does not need to be monitored. Unfractionated heparin does. Unfractionated heparin does. Both are administered parenterally. Low molecular weight predominantly sub-Q. Bleeding risk, both have risk for bleeding. Antithrombic effect is pretty pronounced in both of them. Any questions about heparin? With these drugs, the big risk is bleeding. Bleeding, bleeding, bleeding. If someone's on heparin, you don't give them intramuscular injections. If you do IVs, you make sure that you push down when you're putting it in order to prevent bleeding. By pushing down and applying pressure, that will prevent bleeding. Also on draws, if you do draws by pushing down, that'll help. And yeah, watch out for bleeding. All right, so fonduparin is another synthetic product that looks a bit like heparin. And this product is a direct thrombin inhibitor. And this is used for deep vein thrombosis prophylaxis. This is also given parenterally. And it's used also for this condition called heparin-induced thrombocytopenia, which I'm going to talk about right now. So here is one of the side effects of heparin that can be quite serious. So if you have had heparin multiple times, heparin might form a complex with a protein on platelets called platelet factor 4, or PF4. That heparin PF4 complex looks foreign to the immune system. So the immune system raises antibodies against the heparin PF4 complex. Bloody allergies. And those antibodies then will activate the platelets. So you get massive platelet activation all around the body. So this happens usually 5 to 14 days after heparin administration. 5 to 14 days after heparin administration. If you find antibodies to PF4 in the blood, that's diagnostic for this condition. With this massive activation of platelets, you get clots that form all over the body. So you get DVTs. You get PEs. You also get clots in the extremities. And you get a distal limb ischemia, and it looks like this. Okay, this person is probably going to lose those toes. This person might have to have fingers amputated. This is nothing to screw around with. This is really serious. This is called heparin-induced thrombocytopenia. So that is why when a patient is in bed after surgery, they're on heparin, the nurse may, when the nurse comes around, the nurse checks the vitals, checks the chart. One of the things the nurse will do is the nurse will peer down at the fingers. If they start to see what are called splinter hemorrhages in the fingernails, that's usually where you first see them. Heparin is going to get pulled, and he or she is going to call the provider. Then they'll lift the blanket and they'll look at the toes. They'll look also for splinter hemorrhages in the toes. They'll check their temperature, because usually with this, temperature goes up. And then you're checking the limbs for signs of DVTs, because you get DVTs with this as well. All right, so you get these antibodies against the PF4 heparin complexes. Those will bind to a receptor on the platelet that activates the platelet. The platelets go crazy. And this picture here shows you how this happens. Heparin, PF4, you get the complex that binds to the surface on the FC receptor, binds the FC portion of the antibody. And this is the part about this that is contradictory. You get lots of clots, but your platelets tank. They tank because they're being activated en masse. But because they're getting activated en masse, you're getting clots all over the place. So you get these clots all over the place, and you can bleed to death. Contradictory, isn't it? So what do you need to do? You need to stop the clotting, but you can't give heparin. So what do you give instead? You give direct thrombin inhibitors. Direct thrombin inhibitors. The two main drugs that are given are this one here, argatroban, and this other drug here called bivalirudin. Bivalirudin. Bivalirudin is a peptide that comes from the salivary glands of leeches. Because when a leech latches onto you, it releases very powerful anticoagulants so that the blood doesn't clot while it's feeding on you. If that happened, it would choke on it. So it makes these really, really powerful anticoagulants. And by studying anticoagulants in leeches, that's essentially how this product was developed. So there are 4 things on there, but the 2 that are used mainly, desirudin is not used that much because people develop very severe allergies to it. So it's really not used that much. Lepirudin tends to cause heart issues. So really these 2 are the ones that are used. Argatroban, which is a small molecule that also comes from research on leeches, and bivalirudin. Bivalirudin. These will directly inhibit thrombin. Now, you do not give fresh platelets. What will happen if you give fresh platelets? Right, to interact with those antibodies, and you'll get more clots. Oh, patient, thank you very much. I just screwed you even further. See? Are good intentions enough? No. You got to know what the heck you're doing. So don't give platelets. No, 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 don't give platelets. Okay, HIT, heparin-induced thrombocytopenia. That is after prior exposure to heparin. It is due to an immune response to a heparin PF4 complex. All right, I'll start this. I won't finish this. Warfarin for years was the mainstay of anticoagulant treatment. There is a mass movement away from warfarin, and when we get into this, we'll see why. Warfarin, from a medical perspective, is a colossal pain in the butt. And we'll see why here in just a bit. So, clotting factors 2, 7, 9, and 10. 2, 7, 9, and 10. Before they leave the liver, they're made in the liver. Before they leave, they undergo modification. This modification depends upon the activity of vitamin K. Vitamin K, or as the British would say, vitamin K. Warfarin inhibits that vitamin K mediated modification. Because it inhibits that modification, these clotting factors are released from the liver in a non-functional state. They don't function. Therefore, clotting is inhibited. Now, warfarin, big advantage of it, two of them. One, it's oral. It's only oral, so it's very convenient. Two, it's dirt cheap. And I mean dirt cheap. One supply of warfarin is $3 to $5. Very cheap. So the pills in warfarin are pennies. Literally, they cost pennies. This very old drug, very inexpensive. But the response to the drug is very highly affected by genetics and also very highly affected by diet. So the drug activity varies wildly from person to person. And this drug has to be monitored constantly. Constantly. That's the other big issue with warfarin. All right, we'll get into the idiosyncrasies of warfarin on Monday. Have a great weekend. It's supposed to be cold this weekend, sorry. But there you are.